Welcome back to another session of gastroenterology. Now we'll talk about the presentation of dysphagia. The first most important thing you'll have to rule out in the question is there are two types of dysphagia. One is oropharyngeal dysphagia and esophageal dysphagia. Whenever the patient is elderly and has got a loss of teeth or tooth pain, the pain, temporomandibular arthritis, all these are the clues in the question that you'll have to pick up for oropharyngeal dysphagia. Whenever the patient has got a fracture, whenever the patient is elderly patient, to think of oropharyngeal dysphagia as one of the most important causes for dysphagia. Next, we talk about esophageal dysphagia. Whenever you think of esophageal dysphagia, the examiner wants you to understand that this patient has got HIV, the patient has got a herpes infection, the patient is involved in taking salbutamol nebulizations. That's the most important thing you'll have to remember. Whenever the patient has got HIV, he's immunocompromised. Whenever the patient is immunocompromised, the risk of candidiasis sets in. This causes oropharyngeal dysphagia. But whenever the patient has got burning sensation in the while swallowing, it is the esophageal dysphagia that is because of the candidiasis. Why is this important? Because candidiasis pertaining to the oral cavity, the treatment is nystatin 1 lakh units. Whereas esophageal dysphagia, because of the candidiasis, whenever it sets in, it is the oral fluconazole that you will have to choose as an option. That is what examiner is looking for you to answer this question. So, whenever you find a dysphagia, please differentiate it between oropharyngeal dysphagia and esophageal dysphagia. Whenever you think of oropharyngeal dysphagia, I want you to select the option of referring to speech and language therapist. It is not the doctor's problem. The speech and language therapist will perform a video fluoroscopy. That is very important. Whenever there is no option of video fluoroscopy in the question, you'll have to select barium swallow as one of the causes. Next, when we talk about dysphagia, I also want you to understand in the question, you will have to look if the patient has got difficulty initiating the food or if the patient has got any cough while swallowing. Is there any choking? Sometimes the patient will have nasal regurgitation as well. Remember, patient will have foul smelling from the oral cavity whenever the patient has got Zenker's diverticulum. Zenker's diverticulum is present in the posterior part of the throat. So, in the question, the examiner will mention that the endoscopy is normal because endoscopies usually do not look at the posterior part of the pharynx. It is by the barium swallow or the barium contrast that we diagnose Zenker's diverticulum. That's the most important thing you'll have to remember. Next, if the patient has got difficulty initiating swallowing, it is an oropharyngeal dysphagia. But if the patient has not got any of the problems related to the oropharynx, it is a cause of esophageal dysphagia. Whenever there is esophageal dysphagia, I want you to differentiate if it is for the solids or liquids. We already learned in previous lectures that difficulty swallowing for solids and a food bolus that can be seen on endoscopic is eosinophilic esophagitis. But if the disease or the dysphagia that is progressing to solids and liquids, think of mechanical obstruction. Think of radiation. Patient with elderly, patient with cancer, patient will have difficulty swallowing. Please do a barium swallow because patient has been exposed to radiation and stricture is what the examiner is thinking of and wants you to answer as barium swallow, which can be followed by an endoscopy. But remember, barium swallow usually picks up the stricture. But in order to confirm that it is a stricture, you will have to visualize. So you will have to do an endoscopy, that is a video testing where you can see the stricture, that is the confirmatory investigation for stricture. Next, we talk about cancers that can cause difficulty swallowing liquids and solids. Usually cancers start difficulty with solids and then it leads to progression of liquids. Whenever the patient has got weight loss, whenever the patient has got loss of appetite, please select upper endoscopy as one of the most important answer. I want you to understand that dysphagia, whenever it is solids or liquids or to anything. Why did I say anything? Because in the question, the examiner gives you the option of fluids. Fluid is neither liquid, solid. So whenever there is fluid, it is a motility disorder. It is an achalasia cardia. It is the barium swallow that you will need to select as an option in USMLE Step 2 CK, please. In the question, whenever the elderly patient comes in with the recurrent aspiration, what is the next most important thing? Find out the cause for recurrent aspiration. Please do not blindly treat the recurrent aspiration, because for recurrent aspiration, myasthenia gravis is one of the cause. Oropharyngeal dysphagia could be another cause. Stroke is another cause. These are the three most important differential diagnoses you will have to understand. Not only for USMLE Step 2, I also want you to remember whenever you're practicing clinical medicine for life. Next, we talk about diffuse esophageal spasm. My most important and my favorite differential diagnosis for diffuse esophageal spasm is angina. But diffuse esophageal spasm that comes as a spontaneous pain and it can radiate to back. The difference between angina and diffuse esophageal spasm is diffuse esophageal spasm will be present for hours. Remember, whenever there is diffuse esophageal spasm, the examiner will mention there is an emotional stress, because the examiner wants you to confuse between cardiac angina and esophageal spasm. Remember, cardiac angina and diffuse esophageal spasm, the nitrates and the calcium channel blockers will relieve the pain. But the diagnosis can be established by esophagography. Whenever you do a contrast esophagography, that is graphing the esophagus or looking at the esophagus or taking the images of the esophagus with the contrast, you will find a corkscrew shape of esophagus. Whenever there is a spasm, the gut contracts. Whenever the gut contracts, there is pressure. Whenever there is pressure, what happens? The pressure increases in the gut. So you'll have to pick it up, this pressure. So the definitive investigation is esophageal manometry. Whenever there is esophageal manometry you are doing in the examination as an option, you will find that there is high amplitude contractions. But this high amplitude contractions is important for USMLE Step 1. I want you to understand the differential diagnosis between diffuse esophageal spasm and cardiac angina. The most important differential diagnosis the examiner can give you as a third option is GERD. How do you differentiate that this GERD pain and diffuse esophageal spasm? There is no radiation of the pain. And in GERD, it is not exacerbated by emotional stress. In USMLE Step 2 CK, if you want to diagnose GERD, please remember nighttime cough as one of the most important things. Cough after having lunch is the most important cause of GERD. Next, I want you to understand esophageal strictures. Young female patient, presence of crust syndrome. Think of systemic sclerosis as one of the most important cause of strictures. I also want you to understand that a young female patient with history of depression, psychiatric disorders, now presented with the sudden onset of loss of consciousness or decreased GCS, frothy discharge from the mouth. Think of caustic soda ingestion. Caustic soda ingestion can cause strictures. And please do not perform endoscopy because the risk of esophageal rupture is more in caustic ingestion. You'll find this option in the question by the examiner. Caustic ingestion. Prevent endoscopy. And what did we study? Esophageal strictures. Barium swallow is the first most important thing you'll have to identify, because esophageal strictures can cause narrowing of the lumen, which can be easily picked with barium swallow. I also want you to understand that the examiner frames a question saying that this patient has got malignancy who has been treated with radiation, or patient has got symptoms of crust and has been treated with and has been developing symptoms which are dysphagia, that is to solids, and dysphagia, that is causing weight loss and anorexia. Patricia, could you please switch off your audio? Thanks very much. So in the question, you will also understand that the dysphagia to solids will be there and the patient will not be able to eat. So there will be weight loss. So the next most important investigation you will have to do is barium swallow. In order to confirm it is a stricture, you can do an endoscopy. But the first most important investigation is barium swallow. And how do you treat esophageal strictures? It is both the endoscopy that helps with therapeutic endoscopy and diagnostic endoscopy as well. The most important differential diagnosis for esophageal stricture is esophageal carcinoma because patient presents with difficulty to both solids and liquids. Whenever there is esophageal adenocarcinoma, barium swallow shows that there is narrowing of the esophagus. Next, I want to talk about eosinophilic esophagitis, which I already mentioned, but I want you to remember the management of eosinophilic esophagitis. It is the dietary modifications, it is the glucocorticoids that we give in order to prevent the eosinophilia or control the asthma or control the hypersensitivity reaction that is going on. Remember, eosinophilic esophagitis also has the tendency to develop strictures. So there can be stricture dilation as an option that you will have to do. Remember, in eosinophilic esophagitis, it is the presentation that gives you the answer. In eosinophilic esophagitis, history of asthma with young patient, history of hypersensitivity that is developing heartburn with PPIs, and heartburn is not resolving with PPIs, and there will be intermittent obstruction to the solid foods, please. There can be obstruction, and this obstruction causes retrosternal or the substernal chest pain. That is what I want you to remember. Whenever I talk about esophagitis, pill esophagitis is the most important thing. Not only bisphosphonates, but also potassium and tetracyclines can also cause pill esophagitis. This will be acute onset, this will be sudden onset, this will be related to the medication. The diagnosis is only made by the history, please. No investigations can bring out the eosinophilic or pill esophagitis. That is why you will have to talk to the patient. That is why history is the gold standard investigation or gold standard thing we'll have to do. Next, we talk about the treatment of pill esophagitis. It is stopping the medication. It is most important that identification of the medication that is causing pill esophagitis. Next, I want to talk about achalasia, where the patient develops dysphagia to both solids and liquids. The patient is a middle-aged patient. In the question, you will find that this dysphagia is present to both solids and liquids. There can be regurgitation as well. The patient mentions that the swallowing is better when he is walking around in the room with the wife after having dinner. That's the most important clue. No one does walking when they eat. It is only the achalasia patient who does walking in the question, at least for USMLE Step 2. How do you diagnose it? Again, barium swallow is the most important thing, but the confirmatory is manometry. But make sure you do a endoscopy to rule out other causes. What is the most important cause I'm worried about? It is the pseudoachalasia. Whenever there is achalasia, you'll have to do a pneumatic balloon dilatation. That is the most important. We'll talk more about achalasia in neurosurgery, in gastrointestinal surgery, because myomectomy is what we'll have to do, or myotomy is what we'll have to do. If the patient is not able to undergo surgery, botulinum toxin is what I want you to remember. Patient can also find symptom free or resolution of symptoms with nitrates and calcium channel blockers. When I say that endoscopy needs to be done with pseudoachalasia, I'm talking about a esophageal cancer that can present with achalasia like symptom. But how do you identify pseudoachalasia? It is the examiner that is giving the patient has got a age that is advancing age with history of alcohol smoking with sudden onset of weight loss that is usually suggestive of esophageal cancer. And what is the most common type of cancer? It is the squamous cell cancer that happens to be in the upper lobe, and it is the adenocarcinoma that happens to be in the lower lobe, please. That is what I want you to remember. This is what all the diseases pertaining to the upper respiratory tract, upper gastrointestinal tract. Most of the important disorders in gastrointestinal tract we discuss in the surgery. I also want to talk about constipation and fecal impaction. Whenever there is fecal impaction, remember older patients are more prone for fecal impaction. Young patients are not prone for fecal impaction. Young patients who watch Instagram in the washroom are not prone for fecal impaction, they are prone for hemorrhoids. Most important modern medicine you'll have to understand. Older patients, no Instagram. It is the fecal impaction that you will have to think. It is the chronic constipation that you will have to think. It is the chronic constipation and pooling up of the stools in fecal impaction in elderly that is causing the building up of back pressure and causing the stool to go retrospectively. And then the patient develops everything. The patient develops hepatic encephalopathy if the patient has got constipation, if the patient has got acute liver injury, patient develops confusion because of the fecal impaction, patient can develop delirium. These are all the presentations in elderly patient. I also want you to understand the pathophysiology of fecal impaction in elderly patient. It is because of the impaired mobility. It is because of the decreased secretion. It is because of the decreased food intake. It is because of the decreased fluid intake. The patient develops constipation or fecal impaction. Next, I also want you to understand that the diagnosis for fecal impaction is by rectal examination. But in the question in USMLE step 2, you will find an abdominal X-ray as the answer. Because examiner is not worried about your clinical examination. They expect you to do a clinical examination when you're doing it. Next, I want you to understand the management of fecal impaction. Whenever you do the fecal impaction, whenever you find fecal impaction, the initial management for fecal impaction is you'll have to give enemas, please. Whenever it is not enema, you are giving it, it is the manual removal of fecus that you will need to do. Next, I want to talk about small intestinal bacterial overgrowth. Is it small intestinal bacterial overgrowth? I don't know. It is the Zoom meeting is overlaying it. Okay, small intestinal bacterial overgrowth syndrome. I want you to understand that a middle-aged patient with background history of diabetes mellitus, background history where the patient has got intravenous drug abuse, patient is using drugs, patient is constantly using opioids, patient is having autoimmune disorders such as Crest syndrome, scleroderma. Very important diagnosis not to be missed is small intestinal bacterial overgrowth. The patient will present with bloating. The patient will present with flatulence. The patient will present with diarrhea. This is what you'll have to understand. And small intestinal bacterial overgrowth is basically because of the vitamin B12 deficiency that happens because vitamin B12 deficiency is consumed by the bacteria. Remember, the folate levels are increased because folate metabolism happens because of the bacterial production as well. But what is the most important diagnosis or the gold standard investigation for small intestinal bacterial overgrowth? You'll have to identify that there is bacteria in the small intestine. So you'll have to take an aspirate and do a culture that is jejunal aspiration. In the question, they will tell you that there is abnormal carbohydrate breath test that is identified. So you'll have to think of small intestinal bacterial overgrowth. Whenever there is bacteria in the intestine, you'll have to use antibiotics, that is rifaximin or neomycin. These are the luminal antibiotics that we use. So these antibiotics are used in the treatment of small intestinal bacterial overgrowth. I also want to tell you that there is a question saying that the patient presenting with mild abdominal pain, bloating, and vitamin B12 deficiency, what is the most important thing you will have to identify? When you read the question again, you will understand that there is a surgery involving the bowels. Then you will have to think of small intestinal bacterial overgrowth, and the treatment is rifaximin place. Next, we talk about lactose intolerance. Adults drinking milk, because adults, the lactase deficiency is inevitable. There will be decreased performance of the lactase in adults. So, whoever is increased age, whoever is taking milk, whoever is going to the gym and is taking milk, now presenting with osmotic diarrhea, now the patient presents with abdominal cramps. Think of lactose intolerance. The most important diagnosis you'll have to do is a hydrogen breath test. What is the treatment? They'll ask you as a patient not to take any dairy products. Gastric bypass and these complications, I want you to understand that the most important gastric bypass I want you to remember is patients developing tachycardia, patient developing anastomotic leak, patient developing small bowel syndrome or short gut syndrome. We'll discuss more in the surgery, gastric bypass, and its complications. But I want you to understand that tachycardia is the most important finding in gastric bypass and its complications. In the question, if the patient has got a surgery and if the patient has got tachycardia, please think of dehydration, infection, and anastomotic leak, please. Very important. Whenever the patient has got nausea, vomiting, patient has got surgery, think of adhesions, think of small bowel obstructions. Whenever the patient has got a gastric bypass and patient has got nausea, patient has got vomiting, even after eating, patient is not able to take any liquids. Think of stenosis. What do you have to do whenever there is small bowel stenosis or whenever there is stomal stenosis? You will have to identify the stenosis. You will have to do an endoscopy in order to find out if there is any stomal stenosis or not. Whenever there is stenosis, you'll have to do the definitive treatment, that is balloon dilation, as the first most important definitive treatment I want you to understand. Only after definitive treatment, you will have to do surgery, please. Very important. Next, we talk about intestinal lymphoma. Intestinal lymphoma, I want you to understand the diagnosis is biopsy. Diagnosis is on the biopsy, you find atypical lymphocytes. Without having atypical lymphocytes in the question, you cannot diagnose intestinal lymphomas. Please remember that. Intestinal lymphomas can involve ileocecal valve. Intestinal lymphomas can present as tuberculosis. Tuberculosis, the most important differential diagnosis is colon cancer. All this you will have to identify by biopsy. In biopsy for Crohn's disease, it is the non-caseating granuloma. In sarcoidosis, it is non-caseating granuloma. In lymphoma, it is atypical lymphocytes on biopsy you will find. In tuberculosis, it is the caseating granuloma that you will have to find. And in all these, the patient will present with abdominal pain, weight loss, nausea, vomiting, distension, whatnot, everything related to abdominal symptoms. But please remember, intestinal lymphoma presentation will be present with atypical lymphocytes. Why did I say intestinal lymphoma presentation on this lecture? Because patient will have history of lymphoma or history of past history of lymphoma in the question. That is how you will have to identify intestinal lymphomas, please. Next, proctalgia fugax, my most favorite topic in gastrointestinal system, because questions will be based on this. Remember, whenever there is a female patient and whenever there is history of irritable bowel syndrome or whenever there is psychiatric disturbances and patient presents with rectal pain, Not related to constipation, not related to diarrhea, but these constant episodic pain, algias, proctalgia, that is the pain of the rectum, that is recurrent, that is unrelated to the diarrhea, constipation, resolving spontaneously within 30 minutes is the diagnosis of proctalgia fugax. Many of us will have proctalgia fugax, but we usually do not do anything for that. This is normal in normal patients, normal individuals as well. So the management will be reassurance because the patient will have normal physical examination. The patient will have normal laboratory values. Remember in USMLE step 2, whenever there is a long stem and whenever there is an option of having reassurance, please do select reassurance as the most important thing. But when the patient has got a recurrent pain in a proctalgia fugax, you can try nitroglycerin, please. That's the most important thing you will have to remember. But reassurance is what I will choose. Next, we talk about, okay, we're done. Proctalgia fugax. Very nice. Thank you very much for attending. I will just look at the timetable and I'll find out what is the next class we have. Can anyone tell me the speed of the lecture, or do I need to slow down? The problem is if I slow down, I'll not be able to complete topics in 28 days. That's the most important thing. No one, all gone, all left.